I hear it's 4 bells, and so we're about to get started now. I think we have mostly everyone here who's going to be here. So can everyone hear me? Shake your heads. Thank you, or wave or something. Okay, thank you. Well, good afternoon, everyone. I think I closed my shades enough that the sun is not glaring on this. But I want to thank everyone for being here for our first meeting of the new year of our Commission to Study Mental and Behavioral Health. And, you know, as we move along in this new year, I know everyone is concerned that we, are not able to get back to in-person meetings, but we will continue to do them remotely until it is safe to do so. I want to note that, it's not in today's agenda. I just want to make a quick plug for the importance of the COVID vaccine. And I know you are all aware of the importance of getting the vaccine when it becomes available for everyone. We must all encourage, our friends, family members, and particularly those who are older, like myself, to get their vaccine and encourage those to get the vaccine when it becomes available to them. The challenge, of course, that we have as we've opened up vaccine eligibility to a larger number of people, it puts, I think currently at about 1 million people would qualify for the vaccine, but we only have 500,000 doses of vaccines, maybe a little more than 500,000 doses. So we ask everyone to be patient. But when that opportunity presents itself, I ask that you do sign up and get the vaccine. The sooner we're able to get people vaccinated, the sooner we can get back to normal, and the sooner we can have our in-person meetings. I keep wanting to say inpatient instead of in-person. Moving along, at the end of the year, last year, we did submit the annual report to the governor. The report, we had several recommendations for the coming year, but also an update on the progress of the 2019 recommendations. And many of the Commission's recommendations have been implemented or are in the process of being implemented. Throughout this year, though, I'd like to focus a bit more on implementing recommendations and putting them into practice. Some of which last week, the governor and I introduced 3 pieces of legislation to implement some of the recommendations that we had that focused on removing barriers to treatment. One, to expand the telehealth reimbursement for audio-only telehealth services bill. That's a long mouthful there. To codify the current emergency orders that require insurance carriers and Medicaid to reimburse for audio-only telehealth services. It's going to expand, as we're all well aware, telehealth services for individuals who may not have the video conferencing technology or broadband services. And of course, that's critical to counseling for both substance use disorder and mental health disorders. Now, we're aware that there are bills in the legislature currently that do the same thing, and we don't care which bill actually gets through as long as we get this issue addressed. The other is the healthcare practitioners, telehealth, out-of-state healthcare practitioners. That's another long bill. This would allow healthcare providers who are licensed in other states to perform telehealth services for patients in Maryland. It'll require the same standard of care that all Maryland healthcare providers have to adhere to. It applies to health occupations that provide telehealth services. And just for background, prior to the pandemic, the Behavioral Health Administration conducted a survey on mental and substance use disorder treatment providers. And the survey found that many of the providers were concerned about the adequate levels of staff. 79% of psychologists, 77% of social workers, and 70% of psychiatrists reported shortages in terms of staff. And the staff shortages are much more acute when you get outside the Baltimore-Washington corridor. So the legislation would increase the number of healthcare providers available to address some unmet and critical healthcare service needs in the state. And then lastly, something that we've been working on probably since the beginning of this commission, and that's the Board of Professional Counselors Interstate Compact Bill, which would allow professional counselors licensed in other states that are participating in the compact, similar to the nurses compact that is currently available, to practice and relocate to Maryland without having to go through all of the procedural hurdles that are currently put in place for doing so. The compact would become effective when 10 states join in. It is anticipated that this year, with legislatures across the country having to approve this compact or joining the compact, that we could be up to 10, over 10 in a very short period of time. What it will do, and what we heard concerns for a number of years, and I can go back to when we had the opioid and heroin emergency task force, is that providers of treatment services had a difficult time when they recruited and hired someone who was licensed out of state, because the state requirements would say that they had to go through certain procedures before they could even see patients. And so the providers that were trying to pay these individuals as if they were fully licensed in the state where they were coming from, they could not build them out that way because they could not see patients alone. They had to kind of go through similar to an apprenticeship program or an internship program for a period of time. This would allow the providers to be able to easily recruit people that may, practice and live in another state. We've heard this complaint from a number of providers. Trying to remember the name of the provider in northern Baltimore County or Harford County. Was it Father Ashley's program? They brought that up in particular. That was a challenge that, if they were recruiting someone who's licensed in Pennsylvania, they ran into this challenge, or if they were licensed in Delaware, they didn't live too far away and were willing to work here, or may have been a military spouse who was licensed someplace else, that it made it much more difficult. So we hope this will, address some of those challenges. We'd also like to take a closer look at the assisted outpatient treatment, AOT, and we're working on having a guest speaker to speak at one of our upcoming virtual meetings to talk about AOT and how it works and how it could possibly be beneficial, particularly where you have families that are really having difficulty dealing with an adult family member that may go into crisis and have particular challenges. Another aspect we like to focus on is getting a clear and unambiguous standard on determining when an individual poses a threat to themselves or others, a danger standard. Now that will give those family members, caregivers, law enforcement or public safety personnel clear standards on what actions can be taken to alleviate that challenge. So with all that said, I'd like to roll into the agenda today, and we'll start off with the roll call in terms of our participants who are here. And let me just grab it. And when I call out your name, just signify by saying here or present or whatever you want to say. I'm not going to dictate. Senator Eckert.
Here, sorry, I couldn't get it muted.
Okay.
Welcome, thank you.
Thank you. I know Senator Hester is going to join us shortly. She's not here yet. I think our chief of staff is on.
Hey, Lieutenant Governor, thank you so much for having me. I'm Nick, I'm Senator Hatcher's Chief of Staff participating.
Okay, Nathan, good to see you. Okay, Delegate Kelly.
Hi, I'm here. Thanks for having us.
Sure. Delegate Young.
Good afternoon, I'm here.
Good afternoon. Okay, I think Richard Abbott is not able to attend. Tris Roddy.
I'm here for demonstrator. Thank you.
Okay, thank you. Dr. Jones.
Hi, good evening.
Good afternoon. Okay, sun's still shining. Colonel Butler. Colonel Butler, are you with us? Okay, and I understand that Dr. Boneski is not available. Tiffany Rexroad?
Good afternoon. Glad to be with you.
Okay, thank you. Commissioner Bahrain?
Hi, good afternoon. Happy to see everybody.
Happy to see you. Director Shu? I guess Director Shu is not available. Christian Neely?
Lieutenant Governor.
You're there. I know you, Christian, is kind of detailed to the health department right now, so not sure. I wasn't sure if you were going to get a substitute for a while. Well, thanks for being on. Mary Gable?
I'm here. Happy New Year. Thank you.
Happy New Year. It's never too late to say Happy New Year, right? Barbara Allen?
I'm here, and with Dr. Jones, it feels like evening to me. Been a long day. Good day.
Yeah, it depends on what time you get started, I guess.
Yeah.
Pat Medashevsky?
I'm here. Good
Hi,
afternoon.
Pat. Good afternoon. How are you, Pat?
Good. Thank you.
Okay. Dr. Tripurani?
Good afternoon, Lieutenant Governor. I'm here.
Good afternoon. Carrie Cho?
I'm here. Happy New Year.
Happy New Year. Serena Eckwood?
Hello, Happy New Year.
Happy New Year. Okay, and Kimberly Watts?
I'm here.
All right, Tracy, Happy New Year. Okay. Did anyone have any questions about the minutes of the last meeting? I know Pat had a couple of corrections that were submitted. Any other questions about the, or concerns, edits to the minutes of the last report? If hearing none, do we have a motion to accept the minutes?
So moved.
Move. Second.
All right, all in favor of accepting the minutes? Raise your hand or say aye. All right. Hearing no objections, I guess they are accepted. Thank you. Just with Steve not here, is anyone able to give a report on the Crisis Services Subcommittee?
Sir, this is Heather. Steve Shu is calling into the meeting. He'll be in shortly.
Okay, then we'll go to youth and families and Christian.
Thanks, Lieutenant Governor. Good afternoon, everyone. So the Youth and Family Subcommittee met on January the 11th. There were two items of business that we considered, and it looks like we're going to be seeing if we can make an addendum to the recommendations that we made this year. If not, we can always tack it on to the next iteration of recommendations. But this is sort of a slam dunk. We pretty much came to consensus, although the official vote hasn't been taken because we didn't have the language. But this is a recommendation that that the Maryland School Psychologists Association also supports, which would recommend that the Maryland Medicaid program amend regulations under COMAR to allow for the reimbursement of school psychologists whom are certified by MSDE when they are providing psychological services under an IEP or an individualized family service plan, which is an IFSP. So currently, Maryland Medicaid limits reimbursement to services provided by psychologists licensed by the Board of Examiners of Psychologists under the Department of Health, but this would expand that. So if there was certification by MSDE, then certain services would be reimbursable. Sort of some of the background is according to the parent organization of the Maryland School Psychologists Association, which is the NASP, the National Association. As of February of 2020, 35 states and DC recognized school psychologists as qualified Medicare providers. And specifically, MSDE here is responsible for providing the state share of Medicaid costs for services under the IEP or IFSP. So state funding is provided via an intergovernmental transfer to MDH. So this means that there's going to be no additional cost to the Maryland Medicaid program for expanding reimbursement to certified school psychologists. Hence why we believe it's a slam dunk. So we just, as a subcommittee at our next standing meeting, we are going to actually take a vote to formally submit this to the full commission, I guess, again, as perhaps an addendum to our report, just because I think that this is something that, Maryland could be taking advantage of to provide a greater breadth of services to our K through 12 students. And that sort of falls squarely under the purview of the Youth and Family Subcommittee. In addition to that, Lieutenant Governor and commission members, we had another robust conversation about the involuntary commitment standard, and we are making progress. It's just, we were more or less debating the idea and the concept, but I think the subcommittee really wanted some language to wrestle with. And so the work group there's a work group within the subcommittee that's actually going to come up with some language so that the subcommittee actually can consider, a hard proposal rather than just, this more abstract notion that something needs to be done. So at our next subcommittee meeting, that work group will provide that language to the members of the Youth and Family Subcommittee for consideration. And then if any actions taken, of course, we'll report that to the full commission as well. So not sure if any other members of the Youth and Family Subcommittee wanted to add anything, but I think that's represents all the business that we transacted on the 11th. So I'll turn it back to you, Lieutenant Governor.
Yeah. Dr. Jones, didn't you say the department or your administration is looking at the language with regard to involuntary commitment?
Yes, we are. Yes, we are. And what we have, we have meetings to move this forward. We do have a meeting scheduled in a week to look at definitions around involuntary commitment. So that's where we are right now.
Okay. Because some have talked about, I think I've heard grave disability is something, a part of that. I'm not sure how to define it, but I've heard inserting the term grave disability might be part of it. But it seems as though the challenge is more that it's perceived that the current standard is a bit ambiguous, and so it's often interpreted as the immediate threat versus, because the person is not threatening you right now, or the person doesn't have a sharp object right now, means that they're not necessarily a threat.
Lieutenant Governor, this is Trisha Roddy. I thought maybe I could talk a little bit about the school psychologist issue.
Oh, okay, yes.
Yeah, so it's a bit more complicated, and Christian, we probably should have some conversations around having school psychologists bill directly to Medicaid. So just real quickly, this is a federal audit issue that we had a number of years ago, and CMS told us and took a considerable amount of money back from the Medicaid program and federal matching dollars because you can't have two different licensing standards for psychologists. And the school psychologists don't follow the same standards as a community psychologist. They have different credentialing standards. So it's not necessarily a slam dunk, and there are some issues that we should talk about that we can't necessarily just enroll them like community psychologists and allow them to bill Medicaid.
Breaking my heart, Trish. I will send you the literature that we received from MASP. But yeah, I think we should definitely talk offline. I'll shoot you an email.
Okay, terrific. Thank you.
Thanks.
That's why you're on the commission. You know, that's why. Keep, you know, the commission is averse to keep some of us, like Christian and me, from causing all kinds of problems. So at least, you know, inadvertently causing all kinds of problems. Intentionally is a different story. So,
it's all that COVID brain.
COVID brain. Okay. With that, the finance and funding subcommittee, I guess, would that be Trish or Dr. Bahrain?
I apologize. Yes, it should be me. It would be both of us. So just real quickly, I'll give you the Medicaid update, and then I'll pass it over to Commissioner Breen. We met at January 11th. The Medicaid portion was a very quick update on two issues. Just a quick update on where we are with the system of care discussions. We did not meet in December, but what we were asked to do from the work group members was to develop a plan for future meetings. We asked members to send us ideas, and we're at a point where we're looking through those comments for future agenda items and projects that the MCOs and the ASO can work together to better integrate somatic and behavioral health services. And we'll be meeting again with the system of care to lay out potential areas of focus on February 16th. And then we also gave an update as we're continuing to work on the opioid operational command center grant that we received. That's looking at expanding OMHCs in the crisis stabilization network. So I will pause there and let Commissioner Green give her update.
Thank you. Our update is relatively brief as well. We participated, of course, on January 11th, and the subjects that we covered were first with respect to mental health parity. As everyone knows, we did have our public hearing on November 23rd. We received a large number of very helpful comments, which our team is going through right now. In addition, sort of on a parallel basis, we are doing, the MIA is involved in an investigative effort around the most efficient and effective NQTLs. Once we have been through all of the comments, once we have concluded our research, including our work with other states and how other states have been approaching this and what they have found successful, reviewing certain of their reports, we will reconvene. We likely will not reconvene during session. We'll likely reconvene shortly after session for another public hearing where we will be much more targeted in terms of the specific NQTLs that we expect to be looking at as part of the reporting requirement. With regard to network adequacy, similarly, we had our first public meeting in November, actually December 18th, with regard to our proposed regulations. Again, a very productive session. We were able to, we have many, many public comments. We've taken them back within our internal working group. We've been in touch with a number of stakeholders about whether to try to push this forward during session. Again, what we're hearing back is that, let's wait until after session and we can refocus on the regulation. So that's our current plan in terms of timing. I do want to report that we did have what I think was a pretty successful webinar, and I want to particularly thank the Lieutenant Governor for taping the introduction. It was perfect and wonderful and very, very much appreciated by us, but also by the 166 people that attended. We had a very, very large group of both patients and providers who came, and our focus was on understanding how to access insurance coverage for mental health and substance abuse disorder treatment. And the way that we approached it was a little bit new for us. The way we approached it was through a set of scenarios, examples, things that people could truly relate to. So, we talked about, a hypothetical family by name and walked them through a journey of trying to access mental health care for their adolescent daughter. And that provided, I think, a really excellent framework for people to be able to relate to and ask very, very specific questions. It was a 90-minute session. There was a lot of really active engagement, particularly by providers. And from our standpoint, that was something that was really born out of what we heard in our network adequacy and our mental health parity meetings as we've listened to the concerns and the worries and the circumstances for consumers. We're going to be doing more and more programs like that, particularly outreach to providers, both in mental health and other areas, of course, but that ability to be able to meet, with the MIA, with its most seasoned staff, and at the same time, afterwards have breakout sessions so that you can have one-on-one question and answer, whether you're a provider or a consumer. So we were really happy about that. In addition to the 166 people that attended, we had another 166 or almost 170 that came in through Facebook and other places and looked at least portions of it on social media. So I think that was really good for the public. The last thing that I'll mention is that, it is our intent to bring some of, and I've mentioned this before, but in our next finance subcommittee, it will be our intent to bring in a group like the Bowman Family Foundation that is very focused on mental health services in the self-funded market. Because while we don't regulate that market, it is important to understand and to try to be consistent. And I think it's important for us to understand what groups like the Path Forward are doing in their negotiations with carriers and third-party administrators and their expectations about better improvement, better access to mental health services. And the more that we can learn from each other, I think the better. Because what we want is consistency across payers as much as possible. We don't want people's services to be so incredibly dependent on, what the source of payment is. So we're going to bring them into the discussion. While we don't regulate them, we can at least understand what they're doing and be educated about that. So that's the MIA's part of the report.
Okay, well, thank you very much. I guess any questions on finance and funding? Okay, I saw Steve Hsu signed on. Steve, welcome. Do you have a report from the Crisis Services Subcommittee? At least I thought I saw Steve signing on.
He is on, sir. He's unmuting now.
Are you able to hear me, Lieutenant Governor?
Yes, yes.
Great. Yeah, I please accept my apologies. I've been on for the entire meeting, but for some reason, due to computer glitches, the system recognized me as someone else who was unauthorized to be on the call, and your ever vigilant staff kicked me off the meeting, so I've been on by phone ever since. But good afternoon to everyone, and thank you, Lieutenant Governor, for leading this commission and for your continued focus on mental health and substance use issues, even as we know that your attentions are being drawn elsewhere at this very unusual time. We've all seen firsthand the impacts that COVID-19 have had on the opioid crisis. Our office, the Opioid Operational Command Center, released its quarterly report last week. Preliminary data shows that all drug and alcohol-related fatalities were up 12% through the third quarter as compared to the same period last year. These data highlight an increase in suffering among some of Maryland's most vulnerable people struggling with substance use disorder, which has been seriously exacerbated in the wake of the coronavirus pandemic. We must remain committed to our efforts to ensure that all Maryland residents in need are able to access much-needed behavioral health services. This is why the work of this commission is so important. The Crisis Services Subcommittee last met on January 6th. During our last meeting, we received updates from all three Health Services Cost Review Commission Regional Catalyst Grant Program recipients. The three regional partnerships will work to expand crisis services in Central Maryland, Prince George's County, and the Lower Eastern Shore. The resources provided by the HSCRC to expand crisis services infrastructure through the regional partnerships come at a critical time, and we're grateful for their partnership in advancing this work. Since our last meeting, the Commission has released its annual report. Two recommendations from our subcommittee were included in the annual report, both related to assertive community treatment teams, or ACT teams. Our subcommittee's first recommendation was to continue to identify ways to expand ACT teams to defined areas of geographical need around the state. ACT teams are, as we discussed previously, are an evidence-based model for facilitating interventions for people with severe mental illness. These teams are multidisciplinary, and they meet every day to monitor their patients' progress and to identify needs. ACT teams are generally the first-line crisis evaluators, and they're available on a 24/7 basis to clients who are in crisis. ACT teams have demonstrated success in ensuring that a high level of care is delivered to vulnerable patients, and the model has proven to be cost-effective in other jurisdictions. Additionally, our subcommittee will continue to investigate forensic assertive community treatment teams, or FACT teams. FACT teams are a variation on ACT teams for people who are involved in the criminal justice systems. FACT teams can provide people who are justice involved and who have severe mental illness with a very broad range of services. As with ACT teams, one of the primary goals of FACT teams is to increase the odds of success for these vulnerable citizens by keeping them out of hospitals and out of the criminal justice system. Maryland currently has only one FACT team, which is in Baltimore City. The committee is gaining a deeper understanding of the advantages of FACT teams as well as alternatives to FACT teams. We will continue to gather more information related to FACT teams in the coming months. In addition to our new recommendations, our subcommittee will continue to track progress related to the development of a comprehensive crisis response system, as well as improvements made to Maryland's crisis helpline 211-1. Our next Crisis Services Subcommittee meeting will be held on March 3rd, 2021 at 10 a.m. More detail and login information are available on the Lieutenant Governor's website under the Mental Health Commission tab. Thank you again for your support, and please don't forget that you can always contact the OOCC at help.oocc@maryland.gov, and our recently released third quarter report is on our website. That concludes my report, Lieutenant Governor.
Thank you, Steve. Any questions regarding the Crisis Services Subcommittee? I know Dr. Benesky's not on. I don't think Senator Hester has come on. Nathan, I don't know if you were going to present anything on behalf of Senator Hester and the Public Safety and Justice System Subcommittee.
Absolutely. I'm more than happy to give the committee report today. That's okay.
Oh, okay. Well, thank you.
Absolutely. So thank you so much, Lieutenant Governor, for your continued support and leadership on this issue. Like many of the other subcommittees here today, we met last week on January 11th to review the draft of the SIM Summit report and discuss potential legislative initiatives that are supported by those recommendations. So for those of you who haven't had the chance to see the report quite yet, it starts with a summary of the breakout group discussions, followed by the vote totals at each intercept. On day 2, they held a somewhat informal vote on what people thought were the most important things to come up out of their discussions. The report from those vote totals lists housing as the top priority across all the work groups. And then it was followed by transportation, pretrial expansion, utilization, community one-stop resource centers, trauma-informed care, and the integration of peer services. We are currently taking the input we've gotten from the report, compiling it in a format that is useful, and then making sure that we're improving the report as much as possible. An overarching recommendation of the report is to establish a center of excellence. So a center of excellence can be linked to a university and is usually run by consultants or the university and the state in partnership, who provide technical assistance to counties in regards to structuring and implementing systematic approaches to handling the intersection of mental and behavioral health and the justice system. For example, as we plan to hold the train-the-trainer sessions that are provided through our SAMHSA grant that we secured earlier this year, or I guess earlier last year, through the subcommittee work, a center of excellence would help coordinate that effort and will also serve as a central source of information to make sure we're helping us measure, review, and plan our future actions with accurate information. Our subcommittee discussed multiple paths to the establishment of the Center of Excellence. We were happy to have plenty of interest on it from all the groups on the call, as we want to create a designated entity without reinventing the wheel. Some suggestions included GOCAP, BHA's Advisory Council, and the existing Mental Health Association of Maryland panel that's been meeting for years now. Finally, as the Lieutenant Governor did mention, we discussed assisted outpatient treatment and the possibilities of expansion beyond the pilot or beyond the hospital system if pilots are successful. For the time being, Senator Hester just wanted to clarify that she's not currently legislating on the issue, but that it would continue to be a subject of discussion for the subcommittee. And with that, I will go ahead and pass it back off to the Lieutenant Governor.
Okay, thank you, Nathan. Any questions for Nathan? Okay. We have a presentation from Norm Ornstein and Judy Harris, the Matthew Ornstein Memorial Foundation, that they're going to discuss with us. Norm, Judy, are you all on right now?
We are. Thanks so much, Lieutenant Governor, and thank you and the members of the commission for having us. We're really honored to appear, and we really want to thank you and Governor Hogan and the state for your sustained work in examining all of these issues that are particularly personal to us because of our family history and situation. And let me turn it over to my wife, Judy Harris, for a few comments.
More than a few, but I'll try and run through them quickly. So good afternoon, Lieutenant Governor Rutherford and members of this esteemed and really essential commission. Let me just start by saying that just listening the past half hour has just filled me with hope and good feelings about all of your work. So I really thank you for your devotion to a cause that is so very close to our hearts and for this opportunity to address you. So given the fact that I only have about 5 minutes today, I'm going to try and focus my remarks on only a couple examples of what Norm and I, based on our own experience, and this goes back a little while, but what we believe is most broken about Maryland's current system for the care and treatment of those who, through no fault of their own, suffer from insidious brain diseases that render them incompetent to provide for their own basic needs. First, though, I want you to meet our son, Matthew. Here he is. Can you see him? Beautiful boy. This picture was taken in 2002, the year that Matthew graduated from Princeton with honors and a double major. He was a studious kid, a passionate national champion debater, a stand-up comic, intelligent, kind, funny, athletic, popular, and beloved. Of course, I might be a little biased about some of that. But after college, Matthew headed to Hollywood with his high school debate partner, and they met with almost immediate success as the writers and producers of a hilarious little television show. For 3 years, Matthew happily lived the life he had dreamed of. And then literally one dark and stormy night in 2005, Matthew had some kind of psychotic break. Today, I would know to call it first episode psychosis. No one ever figured out what triggered Matthew's break. He never drank or used drugs, if that's what you're wondering. And in the ensuing 10 years, Matthew never received a diagnosis nor any real treatment. And we were ever able to convince him that he was ill. We believe that our Matthew suffered from anosognosia. His lack of insight led him to conclude that his torment was a result of his soul being taken and his faith being tested because he had done something, he knew not what, to disappoint or anger God. It followed then that the proper response was to study and practice his religion fervently as he did and engage in acts of charity and contrition rather than seek or agree to medical treatment, which in his worldview would have destroyed any possible chance of winning back God's love. If I could leave you with only one thought today, it would be this. Everyone, judges, legislators, lawyers, civil libertarians, the medical community, the faith community, everyone must be educated about anosognosia, the science behind it, and the reason why so many individuals with schizophrenia and to a somewhat lesser extent with bipolar illness end up living on the streets or worse. Laws must be written and must be applied, keeping in mind this serious condition. Moreover, the loved ones of individuals with anosognosia, or better yet, someone appointed to represent the best interests of those individuals, must be enabled to advocate on their behalf and not be blocked, for example, for participating in treatment decisions. My next point, I often say that the worst day of my life was not the day of Matthew's funeral. I was barely conscious that day, massively drugged, I'm sure. But it was on the day when in 2009, I broke the promise that I had made to my son, and I testified against him while he was being involuntarily held for a few days at Shepherd Pratt in Ellicott City. I will never, ever forget the look of stunned disappointment and confusion in Matthew's eyes as I walked into the courtroom. It was I who, desperate to get Matthew help, had made the call to the police that had resulted in his temporary detention. At the time, I knew absolutely nothing about the likely consequences of my decision. And sadly, as I didn't learn until much later, neither did the highly credentialed, well-respected psychiatrist whom I called first for advice. That day, the day I broke my promise and testified against my son, is seared in my memory and always will be. In my mind, that was the day we lost Matthew, though it took another 5.5 years for him actually to die. Because of the laws in Maryland and the way those laws have been interpreted by the courts, I managed that day to lose forever the trust of our son while failing miserably to get him any help through the civil commitment process. I know, and as you mentioned again this morning, today, you are currently reviewing those laws and the way that they are applied, and I really commend you for that work. Norm and I especially applaud that 9th recommendation, which you mentioned in your just released annual report. Thank you so very much for that. I wanted to offer as an aside, I was a practicing lawyer for 50 years, and I'm on a number of commissions and committees now that are looking at and evaluating a model code language for court-ordered treatment. And I'd be happy if it would be of any use to you to connect you with those committees or to bring you that information. One is being run by the National Center for State Courts. It's called the National Judicial Task Force to examine state courts' response to mental illness. Another, which is under the auspices of Mental Health Colorado, and it's brought together about 65 judges, lawyers, psychiatrists from around the country to develop the exact standard that you're going to be working on, and it is tough going. And we've got some draft language. We'd love to share it if you're interested in seeing it. Don't count that against my time because I didn't know I was going to say
No,
it.
we don't count that against your time. Don't worry about that. No, and we appreciate seeing that language because,
Yeah, I will get permission to send it to you. I think it would be helpful because we've been working on it for about 2 years now, and
oh, good. Yeah,
it is tough to get it right. Every comma, every word, is important. So I also wanted to say that in addition to everything that you're doing, the psychiatric profession as a whole is going to have to step up and acknowledge that not every psychiatrist is equally qualified to treat somebody with a serious mental illness. A system really needs to be devised through which psychiatrists who opt to receive additional instruction or clinical experience maybe an extra year's fellowship or something on that order, can be certified as specialists in the treatment of serious mental illness. And a database of these specialists has to be created, not only to make it available to judges and other participants in the legal system, but also to the frantic families that waste so much precious time trying to find the right doctor who really is expert in the challenges that they're all facing. Finally, you're all familiar with how many, many more folks with mental illnesses currently populate our jails and our prisons than our hospitals and behavioral health centers. Matthew never got entangled with the criminal justice system. But after my attempt to get him help on the civil side failed, I would literally get down on my knees and pray that my perfect son would commit a nonviolent felony in the hope that he could finally be ordered by a court to accept treatment. No mother should ever have to pray that her child be accused and convicted of a crime to access treatment for an illness. That said, little did I know at the time that unless Matthew had committed the crime in Miami-Dade County, which I'll tell you about in a second, in Florida, and he ended up in the courtroom of somebody named Judge Stephen Leifman, and been able to be part of his unique diversion program. If that hadn't happened, an arrest would have only made matters worse for Matthew and for us. Norm and I, just as an aside, through the foundation we established following Matthew's death, recently produced a documentary entitled The Definition of Insanity. And that documentary is about the transformational efforts of Judge Leifman and his team in decriminalizing mental illness. It is our hope that the film will serve as a template, and it already has in many places, for other jurisdictions seeking to achieve similar success in decriminalizing mental illness. And we hope too, as Judge Leifman also hopes, that the documentary can serve as a roadmap for the creation of similar programs on the civil side. Should you be interested in a private screening of that film, we would be honored to arrange it and make Judge Leifman available to you for any questions you might have. His program was 20 years in the making, and we're just hoping that a lot of other jurisdictions can benefit from all of his data, all of that tough work that he's done for so long. So thank you, Lieutenant Governor. Thank you, Commission members, for your interest in these challenging and critically important matters. They're literally matters of life and death, as you know. And thank you for the opportunity to speak candidly with you today about some of our futile efforts to get help for our desperately ill son. Matthew died on January 3rd, 2015. Piles of unused civil liberties were mixed in with the trash, but no food, no clean clothes, no working toilet, no means of transportation. The time has really come to get real, and we would like to help you with that. I'm going to turn it over to Norm now, and we have submitted a lengthy PowerPoint with a lot of out-of-the-box ideas and things that we hope you have time at some point to flip through.
Yes.
I'll just conclude by saying that we have I submitted to you some written testimony that I hope you will read with a little more detail. But just to say that we created our foundation, the Matthew Harris Ornstein Memorial Foundation, after our son died following his 10-year struggle, in which we hoped that we could have gotten assisted outpatient treatment if it had been available, that we could have had some ability through a civil process to get him help. Maryland needs to change, and we're really happy that you're doing it. And we're now, we are turning our grief to purpose, and we are available for any help that we can provide, both in thinking through some of these issues of criminal justice, mental illness, and substance abuse, which of course, as you know, often will go together. And it's important also to say that Judge Leifman's program has managed to save lives and save money at the same time. So an initial investment that the state can make and the localities can make can have multiple payoffs. And
yeah, I would definitely like to see that documentary that you put together. It sounds like something that we can, present to our, our representatives who are from the courts. Unfortunately, he couldn't be on this presentation, but also and also our representative from public safety. We all know that our basically largest mental health facility are our state prisons. And it really shouldn't be that way. The story that you told about praying that your son would commit a nonviolent, offense, there was, and you probably saw it in the Washington Post magazine probably 6 months or so ago, where, the parent of a son who was schizophrenic said she couldn't get him treatment until he was arrested. And now he's in one of our facilities here, at Clifton T. Perkins, which is for the, mentally ill, that this is the first time that he's getting consistent treatment by being in the correctional facility. And so, yes, something has to be done. That's why I've been pushing for assisted outpatient treatment, looking at what we can do in the criminal justice system. I was speaking to a group just last week where, they were concerned. They represent people with severe mental illness, schizophrenia in particular, and they're looking for a better definition of at risk to self or others. And one of the things that I said is that with the legislature currently looking at, police reform, a number of the incidents that occur, particularly police shootings, are where they're called to a situation where a person is in crisis, a mental health crisis, and the family are the ones who are calling, and the only ones responding are the police. And even if you say, well, we're going to send a psychiatrist or a social worker, they're really going to have to go out with law enforcement, because if the person, the reason the parents are calling in many cases is because their child is dangerous, or they have attacked one of the family members or threatening a family member. And so you need to have that. So we want to, intercept that person, and Senator Esther's subcommittee is working on the strategic intercept model, but also we need those laws to be changed that make it clear that you can intercept this before you reach that point.
I might add just to what you said, that one core part of what Judge Leifman has done is he's now trained in Miami-Dade, which is a huge county, the 7th largest in America, 7,600 police officers in crisis intervention team policing, a 40-hour program that originated in Tennessee. They've cut the number of arrests in half. They've cut the number of shootings dramatically from 2 a month to 1 in the last 5 or 6 years. They've been able to close a jail and save $84 million over 12 years because of those changes. And at the same time, because of the decline in wrongful death and wrongful assault suits, they were able to improve the bond rating in the city of Miami. So if part of this is to get training, and it can't just be a day or two, it has to be an intensive program.
Right.
Combine it with work with the people responding on the 911 calls and with mental health professionals, it can be life-changing for many.
Yeah.
And if I could just add one point about clarifying the standard. One thing that's just so hard for a family member, and I know was so frustrating and awful for me, is that everything we read and hear is about the importance of early intervention and of getting somebody at first episode psychosis. Right in the beginning, at a time when our son was willing to see doctors and whatever, while he was trying to figure out. But the way the standard has been interpreted now, the person has to be so far along in their illness that it's really too late to do much good. And so I urge you, as you're trying to clarify that standard, take into consideration the tension between how sick you want the person to have to be to get help versus how much more likely the help is to be viable if you get to that person early.
Okay. Well, thank you. I'm going to follow up with you. How does Judge Leifman spell his name?
Leifman. And I will send along to you some pieces. I've written a piece with Judge Leifman. There are a number of things written about him, and we will send you information about how to access the documentary directly. It's we have a website, and it's in the testimony, but I'll also get it to your staff, and I hope you can share it widely.
Okay. Well, thank
We
you.
have presented to many states now with this, with a panel, with their head. You could tell us who you want to talk to, police, public defenders, whatever piece of the, and they'll spend as much time with you as you want. This is so close to their heart. His team has been together for almost all of them for 18 to 20 years, every person on his team. And as he'll tell you, his secret sauce is the use of peers. And that has been an amazing thing to watch.
Good. Yeah, I think some of our people in the courts, as well as our public safety people, probably would want to talk to some of those who have been working with and training. So that could be, I think that could be very helpful for us.
Thank you.
So thank you. Any questions for Ms. Harris and Mr. Ornstein from the commission?
I don't have a question, but I want to thank them for the work they've done. As a parent who's experienced similar, I hear you. And I want to thank you for the presentation material also on your PowerPoint, which does have the links, which I've taken a look at. So thank you for that.
Absolutely. Thank you for giving us the opportunity. I add one more thing, that if anybody is interested in perhaps a presentation, a scientific presentation on this issue of anosognosia, we also have a program with really the world's best expert on that subject, somebody named Dr. Javier Amador, who wrote an international best-selling book. I think it's in 13 or 15 languages now. He's written many books, but this one, his first book, it was called I'm Not Ill, I Don't Need Help. What's it called?
I'm not sick, I don't need help.
Okay.
It's an amazing program he's developed, and we've been putting on, before COVID, we were going around the country and putting on full-day training seminars in this. And since COVID, we've been doing 3-hour online, but every one of them is filled to capacity the minute it's announced. And it's a self-help tool that this doctor has developed. And it gives hope while people are waiting for the laws to be changed, which is something kind of out of their power. So if you are ever interested, he has a TED Talk, I think we've cited, if you want to watch it. And he too would be happy. We work very closely with him to make himself and his expertise available to you.
Okay. No, that could be helpful as well. You know, the challenge and the condition that you're talking about, I mean, we don't let a Alzheimer's patient just wander, and we say that person is incompetent when we diagnose them with Alzheimer's or dementia, but we don't take the same approach when a person also has a brain injury, which can be diagnosed as schizophrenia or bipolar, or maybe some other type of psychosis. We don't take that same approach, and that's absolutely wrong. Just because the person is 20-something, versus much older, and the stories that you give are stories that other parents have had to deal with, because that person that turns 18, they're considered an adult. And if they are lucid enough, and your son, obviously is an intelligent young man, that he could sit in front of, a psychiatrist and give a nice presentation, that he's saying, there's nothing wrong with me. I'm fine. It's everybody else. They don't understand what I'm doing, or they just are upset that I've chosen to go in a different direction. And when you have multiple people, family members, and others who are saying to the psychiatrist, no, this isn't the way, he or she was acting just, 3 months ago. Something is different. Something has changed here.
And let me just add to that. When our son was ill and dying, and I was unable to get him help, my mother was dying of Alzheimer's at the time, and my father had dementia from Parkinson's disease. And all three of their brains were broken at the same time. I would take each of my parents to the doctors, to hospitals, for treatment. Nobody ever asked me to see a healthcare power of attorney. They just assumed that, I loved my parents and I was doing what was in their best interest. My son had a whole life ahead of him for us to try and save.
Right.
How backwards is that? And, I know I've got to shut up, but I will also tell you that in our, I do, my husband's like, but in our PowerPoint, we've included a section on some bold new ideas. And one of those, which is really crazy that we're working with in some states, but we're looking for somebody to be the leader, is the notion of asking people to designate a healthcare power of attorney when they get a driver's license. And that wouldn't have to be, it's a great idea regardless of whether you have a mental illness or not. If you're going to be found bleeding on the roadside and unconscious, how good to be able to go into a database and see to whom that person is given their power of attorney and talk to that person about, can we get your consent? We've got to operate on this person. I believe that there's nobody, certainly no young person, that wants a driver's license that wouldn't do whatever you asked them to do.
Oh, yes.
And I do think that there is a chance that in the case of somebody whose brain is broken and who really is not able to make knowing consensual decisions about his situation, I think that power of attorney could be effective, and it might be one way of being able to contact a loved one. You could change it at any time, but you would always have to have, just a little place like an organ donation thing. I think it's a great idea anyway, and nobody would be suspicious. It wouldn't be in any way tied to mental illness. It's just a sensible idea, and Maryland, we are so thrilled with what you're doing, but we're, aware of the TAC ratings and things whenever I tell my story, in other states. It would be so great for you to be the leaders on something like this. And I don't think some of the things that we've suggested in the PowerPoint, I think are doable. Okay. I had insurance issues and other things. So, okay, thank you so much.
Thanks for all the time. We appreciate it.
Okay, well, thank you all. Okay, I think I asked before if anyone had any questions for Ms. Harris and Mr. Ornstein.
I didn't have any questions, but I did just want to say just a few things. First of all, thank you so much for sharing your story. It was clear how painful that was for you. So thank you so much for sharing so transparently what your experience has been like with the loss of your son and the challenge that you had with his psychiatric illness. And I do want to let you know just a little bit in terms of some of the services that you mentioned that we do have in the state of Maryland. Not to say that I don't think that we have a lot of room for improvement. We do. And that's why we're all here. And that's why we have to hear from families and from stakeholders. One of the things that you mentioned was around CIT training. I do hope that you know, or if you don't know, that CIT training is widely available in the state of Maryland. We've been doing it for many, many years now. And actually one of the best CIT best departments that does CIT training in the nation is in Anne Arundel County, according to a national accrediting organization. So it is something that we stand by, and we at the Behavioral Health Administration look to support as much of that sort of training as we possibly can. And then also around early intervention, your statement about how sick someone has to be in order for them to get help. And in behavioral health, we talk about stage 4 disease, and it's not until people get really, really ill that all the resources are galvanized. I don't know if you know, but through the Maryland Psychiatric Research Institute, they have an early intervention program. They've had one for very many years, but that program has recently been expanding so that we can have wider catchment of younger individuals throughout the state to get referred for treatments so that they don't have to have the same experiences that your son experienced. So I wanted to let you know about that as well. And
in my knowledge, that's not for older. Is that are there, I'm aware of it, but I think it's not really, there's no way to kind of access that if you're 25, 26 and you don't. But I mostly mean that when you rewrite the laws, you shouldn't to get court-ordered treatment. You shouldn't have to be so terribly sick that the treatment isn't going to be effective.
Oh, I see what you're saying.
But I definitely were so supportive of all of those, first episode psychosis, early intervention. Got to push it way down to the school level, and
exactly.
We're so grateful for those efforts. So grateful.
The problem is that with most of this occurs from the ages of 18 to 25 or 27, when the more serious illnesses take place when people are already adults. So.
Right, and the EIP program, you don't have to be under 18. So, but there's a younger age cutoff, but it's not 18.
Okay.
And then the last thing that you mentioned with regards to people identifying who it is that they can reach out to for help if someone does become ill. And one of the things that we've been pushing across the state is psychiatric advance directives, because that can serve that purpose. They're not as widely used as many of us would like for them to be used. And a lot of that is about community education, and then just the transfer of the document from the community to the hospital setting. So there's a lot of work that needs to be done there, but we're definitely trying to do what we can to make sure that people are able to communicate when they're not well, how best to help them when they become ill.
Exactly. And, those efforts also are fantastic. I really want to make clear that because of our experience, we are only speaking to a very narrow segment of the population. It's those people who are living in the street. It's those people who have no idea that they're ill. They will not fill out a psychiatric healthcare power of attorney because they don't think they need treatment. They don't want treatment, et cetera, et cetera. So our crazy idea is just meant to catch people before they're sick.
Exactly.
Our son would have probably even done my laundry in order to get a driver's license if that was a condition attached to it. So.
And wouldn't just say no more when he turned 18, would have been there.
Right. And even just having the term psychiatric is going to dissuade people.
Precisely. Precisely.
Even if they're not suffering, or they haven't had a crisis or a breakdown, just the fact that it says psychiatric, I think you're going to have resistance right then.
As long as there's still stigma, and there is.
Yeah,
exactly.
And different providers call it different things. You can call it a mental health advance directive, but it's a psychiatric advance directive. But and those of us who are in this space, we use the language that works for the person who we were working with. And so we don't allow or encourage people to get hung up on what we're calling it. We're just trying to get down, what it is that that's important for them, how to de-escalate them if they become upset, who to contact, what medications do they prefer or not prefer, what are their side effects to other medications that they're not going to take, what if they have to take something against their will, what's the medicine that they should take because it's going to work for them. So all of those sorts of details would be contained in that sort of a document.
I have a question about that. Have you found, I'm really curious about this, I don't know if you have any data or experience with this particular thing, but when somebody you're working with signs that and then is in crisis, do they ever then just revoke it and say, I don't want you talking to my mother. I don't care what I might have said.
But people revoke things all the time when they're not well. Yeah.
Yeah. So that's the other kind of problem.
But I think that part of the arrangement says that even if I say that I don't want you to do it, I still want you to do it. So there's agreements that people make when they're well, so that you know better how to manage them when they're not well, how to be helpful.
And I don't know how courts will interpret that. I really don't. So it's a really important thing to be doing.
It is. Well, and thank you so much for sharing your story.
Thank you for your hard work and dedication.
We're available anytime. Thanks again.
Well, thank you again. We'll now get to some of the public testimony. And hopefully I pronounced your name correctly. Aisha Mann.
Hi, yes, you came very close. Thank you.
How close or far away was I?
My mom pronounces my name Aisha, but you can
Aisha.
pronounce it any way you see fit.
Aisha, okay.
Thank you. Thank you so much for sharing your story to the Ornsteins as well. It was very moving, and I appreciate how much that took. My name is Aisha Mann, and I'm speaking today in support of all of that incredible work that we were just discussing about the implementation of AOT in the state of Maryland. I'm also representing the agency for which I am the MSW intern, Help in the Home in Rockville. Our agency provides support to people with severe and persistent mental illness, people for whom this AOT bill would be life-saving. Many of our clients lack the capacity to recognize their illnesses, and that anoscosia that we were just discussing really causes them to refuse or avoid voluntary treatment. The only way for me to drive home this point is to share another story. This one is about Jack, a client I will refer to as Jack. He's been caught in that revolving door of involuntary hospitalization 12 times in 4 years. And after each hospitalization, he leaves outpatient treatment and the cycle repeats. He's been arrested, kicked out of various apartments for property damage and disturbances leading to homelessness. And the homeless shelter has banned him because his medication non-compliance led him to throwing a knife that fortunately embedded in the wall behind his human target. Only by chance has Jack not harmed or killed anyone or himself. So many of our clients and those who care for and live with them don't have the luxury of time to wait. We cannot afford to give a client like Jack, for whom every peer, family, and supportive intervention has been attempted, the time to come to voluntary placement, or to wait until his psychiatric needs meet criteria for us to file an emergency petition. With a real AOT in place, Jack could be supported in maintaining compliance with his medications and services through a judicial order to do so today, and be on the path to stabilization and recovery, something he and his family and our community all need to get. In my research on ethical-based practices with this population of adults, it's vital that clients feel a sense of efficacy and autonomy over their own lives. Yes. And it is instructive to note that when applied well, AOT improves quality of life. In the New York program, 81% of patients said AOT helped them to get and stay well. 75% of them said it helped them gain control over their lives. I hope that soon Maryland will be able to report similar statistics, but not numbers that reflect the higher incarceration, arrest, violence, and escalating healthcare costs that the current revolving door perpetuates. I urge that the state of Maryland establish a new pilot program of an evidence-based, assisted outpatient treatment program as recommended by the Treatment Advocacy Center, the American Psychiatric Society, and SAMHSA. Thank you for hearing my plea, and for those of us working in this field, we need to continue larger and more extensive presentations from the Treatment Advocacy Center and the crucial work they are doing. Can't get enough of their hard data. Would you please consider adding more of their work to a thank you.
Well, thank you. And, thank you for all the work that you're doing. And, thank you for coming in and talking about AOT. We're one of very few states that does not have an AOT legislation. And I mean, we hear it from parents and you as a provider that it's something that can help this, as the Ornstein and Harris talked about, you know, a small segment of those who are severely ill and often are the people that we see on the streets, that because of their illness and because they don't necessarily recognize their own illness, that at least presenting them with some structure can help them in a way. So thank you. I'm going to call on, or any questions for Ms. Mann? Okay, thank you. I'm going to call on Carol McCabe. Carol McCabe. Okay, I guess Carol's a unisex name, so I don't know if it's a Mr. or a Ms.
Sir, they are not signed into the meeting.
Okay, so person McCabe is not available. Lucen, I think it's Lucen. Parsley?
Yes, I'm here. Good afternoon, Lieutenant Governor.
Did I pronounce your name properly?
You did. It's Lucienne Parsley.
Lucienne, okay.
I'm an attorney at Disability Rights Maryland, which is the designated protection and advocacy system for individuals with disabilities for the state. I am the legal director there. I also manage our PAMI program, which is protection and advocacy for individuals with mental illness. We are a private nonprofit law firm, but we are mandated to ensure that people with disabilities are protected from abuse and neglect, rights violations, and we monitor the state hospitals, we investigate deaths, allegations of sexual abuse, suicide attempts, serious injuries, and we also engage in systemic advocacy. And while we think there's a great deal of helpful information in the recommendations, including the crisis response recommendations, the sequential intercept model, and many other things, we do have concerns with changing the involuntary commitment standard, which we feel already does protect people. And quite frankly, in our work, we often see people who are involuntarily committed who don't meet the standard. So we've seen that as a problem as well. We do want to point out that, you know, Maryland does have a guardianship law, and for people who are incapable of making decisions on their behalf, guardianship can be a possible solution. A guardian cannot institutionalize someone in a psychiatric hospital or commit them without a court, but the standard as it exists in Maryland is constitutional. It protects people's rights because it requires that someone not have their liberty taken away from them unless they present a danger to themselves or others. We do support the suggestions for advanced directives. We've supported that for many years, and also the suggestions for increasing the use of peers in engaging people and providing treatment and recovery from mental health crises. The second thing we wanted to point out was the recommendation for exploration of assisted outpatient treatment, AOT, or outpatient civil commitment for people exiting the criminal justice system, which on its face seems to present some concerns if people are being subjected to AOT simply as a result of their disability or their diagnoses. You know, when people exit the correctional system, they should be subject to the same treatment as anyone who does not have a disability. And I will point out that people with disabilities, you know, are less likely to commit crimes than to be victims of crimes. But, you know, right now we have the Supreme Court's decision, the 19th, and we would suggest that, I'm sorry.
You're breaking up, at least on my side.
All right, so I'll just,
Yeah.
okay.
Something is happening.
Well, I'll conclude that we urge the commission.
I just got you.
I'll conclude then. Thank you very much.
Yeah, all I heard was urge the commission, and then it stopped. I don't know if anyone else heard more. So the connection wasn't good. The challenge, I know you're concerned about the changing the standard for civil commitment. You know, I think there are a lot of people disagree with you that it's not very clear. I believe other states have a different definition that's a little bit more clear than we have, and it does meet constitutional scrutiny. You know, and you've heard from families of adult family members where that becomes a particular challenge. And we're one of very few states that does not have AOT. I think we're one of, 4 states that doesn't have that type of statute. And I mean, we're no more conservative or even aggressive than some other states that do, including New York and I believe Massachusetts. So I think that it can be shaped in a way that protects people's liberties, but can provide some structure to an individual that is, suffering from severe mental illness. We're really not talking about, we really are talking about a small segment that are severely ill, and you probably heard the testimony from Ms. Harris and Mr. Ornstein. Theirs aren't the only testimonies of parents that find the current system not working well for them and not working well for individuals who are suffering from severe mental illness. And to group them with everyone that may have a disability of some sort, we have to do something about this, and the status quo just is not working. And so we'd want to work with you, but it can't be just a no, 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 but there needs to be a way to address the challenges that these parents are facing, and the person should not have to go to jail to get consistent treatment. So it's, or, the parent that loses their child should not be in that situation either. We're supposed to outlive our kids. So I appreciate your concern. It's just, we have to figure out a way to work together on this. I don't know if your connection got any better.
Okay. We'll submit our public testimony, our written testimony to you. I don't know if my connection is better now, but I will say that, Maryland does have many, many people that are waiting for support services that are not able to get into services. And also that, when you look at states that have AOT programs, their outcomes are not better than ours, which typically is seen as pretty good. That forcibly medicating someone or requiring them to accept treatment in the outcomes that parents wish for. I too had a family member who was unwilling to take medication, and it's a very difficult thing for a family. I absolutely acknowledge that. There are very significant problems that come from forcibly medicating people. And just because someone is involuntarily committed does not mean they're going to meet the requirements for 10708 to be involuntarily medicated. So the way to resolve this is to reach people where they are with peer supports and services that actually meet people's needs. You know, many of the people that we see that have been arrested or homeless and not getting services have been discharged by mental health community providers. So having services that are evidence-based, that are trauma-informed and really meet people where they are, make the system accountable to the person, are a much better way of engaging people for the long term. You know, there's a whole lot of research now saying that the long-term outcomes of psychiatric medications are really unclear. That, you know, even NIH and SAMHSA have said that long-term people's outcomes tend to be more negative under a lot of the psychiatric medications that are provided. So people should have the right to make decisions about what works for them as long as they're not presenting a danger to themselves or others.
No, I understand that. And some of the conversations were not just about forced medications. I think Ornstein and Harris were not necessarily talking about that. They were talking about just the diagnosis of their son and getting help because he didn't believe that he needed help. And so that's another step. And that's why I said there may be places where we can all work together and not just, to formulate something that can put some parameters around how you get services to a person. And in the situations like what they were talking about, and there have been others who've had very similar situations where, and we know the reason we have this commission is because there are barriers to treatment. So it's not just, we're talking about one of the barriers to those who are severely ill, and how do you handle that person who really can't take care of themselves or has a very difficult situation. But, in that whole intercept model and getting to them early, there are barriers to that treatment. So we're talking about just part of it, part of that whole process. And there are people who have less severe conditions that have difficulty getting treatment and accepting it, as well as the stigma that's associated with it. So, I thank you for your testimony and look forward to reading your written testimony. I don't know if anyone has any questions for you. No questions for Ms. Parsley? Okay, well, thank you again. Elvira Arnold. Elvira Arnold?
Yes.
Oh, okay, there you are.
Hello, good afternoon. I have a very close family member who suffers from mental illness, and she has a long history of hospitalizations, about 25 hospitalizations, and to no avail. She would be discharged after a very short period of time, at the most 1 week, and then with no follow-up services. So this family member has been homeless for about 3 years after being discharged from several hospitals, and it became a pattern: hospital, shelter, shelter, hospital. When in shelters, there was no proper follow-up in the midst of unsanitary conditions, and she was even victimized by caretakers and other shelter users. All outpatient treatments have proven a failure. Meanwhile, she has lost insight of her illness and need of treatment. The last we know of her is that she was thrown out of the shelter she was in, and she was out in the streets for a week or so, and in a total state of psychosis. She committed a felony. She's presently incarcerated. So I believe there must be a more human, effective, and less costly way and traumatic way of taking care of our population with mental illness. One step, I think, in a good direction would be to establish in Maryland an AOT treatment. So this has proven results in reducing homelessness and incarceration. So I would request that the commission include that in their recommendations. Thank you for working towards the improvement of a broken system.
Thank you very much. As you probably heard, there are those who are not fully on board with the AOT concept, but as I was trying to say, I think there is room to move in a direction that we are able to take care of people like your family member and others that really are in a difficult situation and need to be able to address those issues. Trying to address early is one thing, but when they've already passed, go, and they're at a point where they have a severe brain injury, then a different approach has to be taken. So hopefully we can all work through that. Ms. Nicole Briscoe, does anyone have any questions? I'm sorry, for Ms. Arnault.
I was just wondering, what would be that different approach?
Well, I don't know what that different approach is. I'm just saying that you may have heard Ms. Parsley just a few minutes ago. She was not thrilled with AOT or making a change to the current standard for involuntary commitment. And I think that there is room to try to address some of the concerns that she and others may have associated with assisted outpatient treatment and changing the involuntary commitment standard. I think that there's room to improve and be able to help people like your family member, as well as other family members that are beyond that initial intercept. She mentioned about focusing a lot on that initial intercept, at an early stage, which is extremely important. But you have to also deal with people where they are, not necessarily, and if they're further down the line in terms of their illness, then, other actions have to be taken. And so, putting some parameters around, their liberties may be the only thing that is helpful to themselves and others. And so, I'm willing to work on that. I just think that there are a lot of people, and I'm saying I'm willing to work with them to try to come to a compromise. But so far, what we hear from some that oppose assisted outpatient treatment, it's just no, 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 no. Versus how can we really address that person who's on the street right now?
Mm-hmm. Thank you.
Okay. Anyone have any additional questions? Okay, Ms. Nicole Briscoe.
Yes, I'm here.
Yes.
Good evening, everyone. And thank you first and foremost to the Lieutenant Governor for holding this meeting. My name is Nicole Briscoe, and I am a clinical therapist for Choice Clinical Services, as well as a member of the Maryland Public Health Association. And I'm here to advocate on behalf of increased mental health resources and support for our African American communities, as well as our youth. As a clinician, I have witnessed firsthand the rapid decline in mental health and well-being due to the civil unrest that our nation is facing, as well as the racial injustice that our nation is facing and economic despair that we're facing due to the COVID pandemic. Many of the clients that I have seen have had an increase in depression due to social isolation as well. And research and statistics have shown a 10.7% increase in suicidal thoughts among ages 18 to 24, and among a 25.5% increase among minorities. Because of those findings, and to that end, we would like to know, and I would like to know, what additional treatments and mental health supports have been or will be put in place to address the mental health needs for individuals of the minority community the youth, and for those who are uninsured due to the lack of jobs. Lastly, I would like to know if there's any way I can assist in this matter. I'm more than willing to serve as a resource and a vessel to help increase the availability of mental health treatment for these populations because they are greatly in need.
Okay, well, thank you. Well, one of the things you could, you're always free to join one of our work groups that we already have established. You probably heard, I think you were on in the beginning where we went through this crisis services group, youth and families, courts and public safety and judicial systems, and I'm forgetting what, financing and insurance. And because we're in now starting our third year, it is possible to have a third group, a fifth group, I should say. But, some of what some of the groups that you're advocating for, youth and families is, definitely one of them, because you were talking about the impact on young people in particular. I think, it doesn't hurt having a voice that is looking at our diverse populations, but it could be crisis services or any of the other groups, or if you find that those groups don't necessarily meet your needs, we'll talk about it and possibly another one. But we're trying to, the intent of the commission is looking at the challenges to getting mental health services for people in the state, breaking down the barriers to getting mental health services. Part of it is also eliminating the stigma associated with mental health. You mentioned that statistics are showing, in this year of COVID, the isolation and people suffering from depression. A lot of times, and these are the people who are telling you that, or telling the pollster that. A lot of times people are, in particular in, I'd say in, as an African American in the African American community, there's still probably a greater stigma associated with admitting that that something is wrong. The families do not want to say, that, the crazy uncle or those things, or this person is not quite there. It's always, don't air the dirty laundry kind of thing. So it's reducing that stigma is one of the missions, to be able to talk about this publicly, that it's okay to not be okay, and so I'd invite you to, join us and, and make sure your voice is heard.
Thank
you.
So
thank you for, for tuning in, as I can say, since we're kind of on TV now, so, or something similar. So.
Thank you.
Any questions from Ms. Briscoe? Okay. Well, thank you. And as was mentioned earlier, if you go to my website, it has the Mental Health Commission and the different subcommittees and the subcommittee meetings as they are coming up. Our meetings, typically the full commission is quarterly, but the subcommittees are meeting for the most part monthly. And sometimes they have, special guests that come in and talk about a particular issue that they're looking into. So that could be helpful.
Thank you, Lieutenant Governor. I'm certainly going to check out your website because this is a cause that I'm very passionate about. So I will be looking into that.
Okay. Well, thank you. Okay. Katie Rouse. Actually, we have two people that are from the On Our Own Maryland, Inc. Can we ask that either you all combine or one person speak, either Katie or Carissa Ballinger, speak on behalf of On Our Own Maryland?
That's a great question. I'm going to say that I would ask Teresa to please share her experience, and I would be happy to submit written testimony from the organization of On Our Own of Maryland if we're short on time. Although I hope that in the future we will both be able to share some stories with everyone here. Thank you.
Okay.
Can you hear me okay?
Yes.
All right, thank you so much. Good afternoon, Lieutenant Governor and Commission members. Thank you for having us today. My name is Sharisa Billigmeyer, and I am the Program Assistant at Honor Own of Frederick. We actually have many Honor Owns over Maryland, and Katie Rouse is actually with Honor Own of Maryland, and I'm with Frederick. So I'm the Program Assistant. I'm also a certified peer recovery specialist and a registered peer supervisor, and I love being able to serve my peers. I myself have been, I'm here to share a little bit today about my personal experience with forced treatment and this approach in psychiatric settings. So I have been receiving psychiatric care since I was 17, and I'll be 37 next month. It's been a little while, and it's often felt like something I really had no choice with. And even in the moments where I knew that I needed help and needed a higher level of care, there were always times when my ability to make decisions was disregarded. And of the 8 times I've been hospitalized in the past 20 years, only 4 of those times did I feel as if it was my decision. I felt for a very long time that I have had no choice in the type of care I receive. And I've never wanted to be on psychiatric medication, but it's always been forced on me. My story is a prime example of the potential harm and trauma that is caused when patients are stripped of their choice. And it also shows how people who struggle with mental health issues are discredited and often not believed. So in 2007, while on a trip out of state, I discovered that I had been blacking out. I had recently learned that seizure disorders can frequently exist alongside psychotic disorders. I was concerned, and when I returned home to Maryland, I was being admitted to an outpatient program. And I expressed my concerns to the intake staff, and I hoped that they would do some diagnostic work to figure out what was wrong and what was possibly going on beyond my mental health struggles. I was worried. I hoped that they would do some diagnostic work. And the staff asked me to sign myself into the hospital as an inpatient. And they didn't tell me what I was signing myself in for. And I assumed that it was going to be for diagnostic work, that I would have some scans. I'd have a doctor looking at my, issues and ruling out whether or not there was a seizure type thing. And 10 minutes later, I found myself on the psych ward. That was about a 2-week stay on the psychiatric ward, and not once were my concerns addressed by a doctor about having seizures. Not once then, and not once since has anybody addressed that issue. My experience at the hospital ended up being traumatic. During this stay, there were multiple occasions where I was forced to remove my clothing in front of male guards, and I was forcibly medicated without my consent or my knowledge of what the medication even was. I know this is often seen as standard protocol, but it's incredibly humiliating and hurtful. Being forced into the hospital and frequently told that I'm getting the help I need when often what I really get is re-traumatized. In 2015, I voluntarily admitted myself to Shepherd Pratt. While there, they informed me that they wanted to put me on lithium. I have a pre-existing thyroid condition, and my psychiatrist had never prescribed it to me because of this. I declined and reminded them that I was not supposed to take lithium. Shepherd Pratt gave me an ultimatum. They said, take the lithium or I would be subjected to electroshock treatment. As I had no idea what the long-term effects of electroshock treatment could potentially have on me, I gave in and agreed to take the lithium. Immediately after I was released, my psychiatrist took me off of the lithium because she did confirm that it would have affected my thyroid. I am happy to say that I haven't been hospitalized in a few years, and I attribute that to the community of peers that I have found at Honor Own of Frederick County. They've been an incredible support to me, and they've supported me in my goal to come off of psychiatric medications and have supported me in every aspect of my recovery and have made a huge difference in my life. I urge you to listen to my story and the stories of others like me and understand the harm that forced medication and treatment can do to someone and to our service system. It's often dehumanizing and it's often re-traumatizing. It instills the belief that individuals with serious mental health issues are unable to make treatment decisions on their own, which can cause rifts between providers and consumers. Very important information like physical health conditions can be ignored. And if we are to cultivate a more recovery-focused behavioral health system, we really need to also listen to the voices of people like me who receive these services. Thank you so much for your time.
Well, no, thank you. That's, extremely informative. And I had no idea that they were still doing electric shock treatment. I thought that was a bygone era. Like in, leeches and things of that nature, bleeding, people. I didn't know that was still something that was going on.
And some people actually do choose to take electroshock treatment voluntarily. That I knew fellow patients who did make that choice, and it can be a treatment that people choose. So it's not that electroshock doesn't necessarily work for people. It just wasn't. I wasn't even given a choice.
Yeah. I mean, what does electroshock treatment do other than shock you? I mean, I'm not an expert, and maybe Dr. Trippiani can help on that.
Yeah, sure. The electric shock treatment is actually a very effective treatment as long as it is used for a specific condition. I guess we have this negative notion about electric shock treatment because of the history and the abuse that it has gone through in the past, and also from the movie. That unfortunately creates very negative perception, but especially the electric shock treatment is used for patients who are catatonic or with severe depression, with severe suicidal ideation, who are not responsive to medication. The current electric shock treatment that is administered now is very sophisticated. Patient is anesthetized by an anesthesiologist in advance. And also they are given, once the patient is anesthetized, a patient is given intravenously a muscular relaxant, so it completely paralyzes all the muscles. And then a controlled electrical stimulus is given to the brain through a specialized machine, wherein you are basically creating an electrical seizure in the brain. An electrical seizure in the brain, it is supposed to create a flood of certain hormones in the brain like dopamine. And what it does is it just gives a huge boost to help the patient to recover much faster. And I have seen patients, and of course it has to be used only in selected patients, and it does save patients, and it does actually give a miraculous recovery to patients who are totally catatonic or who are at the verge of decompensating to the point they might even die, or those with the severe depression. And another indication is it is also postpartum psychosis. Women who right after the birth can develop severe postpartum psychosis along with the depression. And that is also one of the main indications. The indications are very small. In the past, we're talking about 1940s, 50s, and 60s, electric shock treatment used to be used for everyone, schizophrenics, psychotics, and everyone. And electric shock treatment should not be used for schizophrenics or psychotics because it is not effective for those patients. It is not effective for those patients, and it should not be used. And of course, electric shock treatment can only be given with an informed consent by the patient. It can never be administered involuntarily.
Okay. Maybe the way you explain that, maybe there should be a different term, because some of us are old enough to, like you said, remember some of these horror movies, and
that's right, yeah.
And that, like you said, and the time when it was given to everybody without consent, almost like you were experimenting. Maybe the way you explain that, it should be the terminology should be a little different.
The administration of the electric shock treatment in the last 30, 40 years has become evolved, and it is very modern. And the reason why a patient is paralyzed right after administering a general anesthesia is so that there is no seizure. Basically, electric shock treatment is to create an electrical seizure in the brain. Electrical seizure in the brain. And in fact, the way it was originally discovered was by an Australian neurologist who found out patients who had history of seizures since they were childhood did not have any mental illnesses or severe mental illnesses. Maybe the seizures had a protective effect in the brain. So that's how the electric shock ECT, what's called actually we don't call it as electric shock treatment. It is called ECT, electroconvulsive therapy. That is the actual current terminology.
Okay.
ECT.
Maybe we should use that terminology.
Yeah.
Okay, so you're kind of rebooting the brain in a sense. So
That's exactly. You're just booting by flooding the hormonal releases in the brain by giving a controlled electrical seizure in the brain, creating a grand mal seizure in the brain, but not in the rest of the body, so that the patient is not affected because you are anesthetizing the patient and you are paralyzing all the muscles, a short-acting paralyzing, and the patient recovers within about 10-15 minutes, and in the observation area, probably about an hour or so, and then the patient gets back to wherever he is, whether inpatient or outpatient. It is actually administered even as an outpatient also.
Okay. Well, I mean, Carissa, how did you pronounce your last name?
Teresa Billigmeyer?
Bellickmeyer, because they have Ballinger here, so sorry. Okay. No, thank you for the, that information. And I think it goes to some of the things that Ms. Harris was saying in terms of, the specialties of psychiatrists that, not just like every doctor cannot handle every case, and every lawyer can't handle, they're not a specialist in every case. And perhaps it's the same with psychiatrists that, they can't handle every situation the same way, that there's certain specialists that can handle certain things a certain way. And you're right, the peer recovery and definitely listening to the person who is, has a challenge in terms of, mental health challenge. And, I see mental health challenges as really not any different from a physical health challenge. It's just a challenge associated with your brain versus with a nerve in your leg, so it's, but it's listening to everyone. But I think that, all this information coming together, I'm trying to break down the barriers to getting treatment. And then at the same time, being able to, address those, who have severe issues, and how do we do that and not have the kind of abuses that you've talked about that took place. So it's trying to reach that point where we could address, the challenges that are, out there, as was discussed with people who are on the streets, because there's this revolving door that goes on with them. And then at the same time, to not then be subjected to, abuse when they are in a situation where they should be cared for. And what you described, that you were blacking out, should have been the first thing that they were trying to diagnose. Well, why is she blacking out? And we have had testimony before that people who suffer from mental illness often have more physical ailments and run up the cost because they don't diagnose it. They just, assume this person, has a mental health, history, so it must be a mental health issue that they're having, versus, no, they really have a broken leg, or they really have, something, a clogged artery or something of that nature. So, thank you, and for your testimony and sharing your story. Does anyone have any questions for Ms. Bellimeyer? Did I get that right? Okay. Senator Ecker, you were muted when you were just trying to.
Thank you. I just want to say thank you. I think it takes a lot of courage to come before a group, even if it's Zoom, and share one's personal account. Thank you. Years ago, one of the things that used to happen, and I will add, I worked with a psychiatrist, and he said you really can't get a full picture on what's going on with the mental illness unless you rule out any type of seizure disorder. So he was a great advocate that everybody have a sleep-deprived EEG to be able to look. And I think we've gotten away from some of that through the years. I don't know, but that used to be one of the things, or whether you get a PET scan or a brain scan, to be able to look and see what kind of differences are going on, because there are many variations on seizure disorder. And I think it is important that we sort that out. And he was a great advocate for something called limbic system disorder. And that was where somebody who demonstrated something that looked like paranoid schizophrenia was actually a seizure disorder, and so did respond to those medications. And that's how we've gotten to use some of the anti-seizure medications to treat variations in some of the diagnostic categories. So just a little history lesson from working for 50 years in a state facility where we came out of the era where everybody received shock therapy indiscriminately. And so it was banned in Maryland at that time. But it's a very useful treatment today because of the state-of-the-art advances.
All right, thank you. I think we'll have time for one more person, Ms. Ann Geddes.
Hello, thank you, Lieutenant Governor. I'll try to go quickly. My name is Ann Gaddis. I'm the Director of Public Policy for the Maryland Coalition of Families. MCF helps families who care for someone with behavioral health needs. Using our personal experience as parents, caregivers, and other loved ones, we provide family peer support services and navigation services to caregivers of children and young adults with mental health needs, and to any loved one who cares for someone with a substance use or problem gambling issue. We have a family peer support staff of about 50 employees. They all have lived experience caring for a loved one with behavioral health disorder. We also have administrative staff that also has, many of them have that lived experience. We have found that there is not universal agreement among our staff or the families that we support regarding involuntary commitment. And I mostly want to make that point that not all families are in agreement that this is the way we should be moving forward. Personally, I am the parent of a child who is now 32, who was diagnosed with bipolar disorder as a teen. Since he was under 18, we did have the power to have him committed to inpatient treatment, and we did this multiple times. He still talks about how traumatic the experience was, especially since he was subject to the use of restraints and seclusions during his many hospitalizations. He says that it has forever turned him off from receiving mental health treatment. Indeed, since he turned 18, he has refused any kind of psychological treatment and medication. We must be aware that this aversion to receiving psychological services can frequently be the consequence of involuntary treatment. After our son turned 18, we had very sporadic contact with him. We subsequently learned that over the next few years, he had multiple emergency department visits and brief inpatient stays. He began using illegal drugs and ultimately developed an alcohol use disorder. Despite all this, I remain concerned about the expansion of involuntary commitment. I believe that we need to focus on the provision of evidence-based, culturally competent, trauma-informed care that is appealing to individuals and meets a person where they're at. This will take a tremendous investment, and I think we need to be prepared as we look at AOT. We need to be prepared to make a tremendous investment in these kind of services. This is the right thing to do, and it will both help those who are suffering from severe mental illness and their families. Thank you.
Can AOT, I think the pilot that Baltimore City ran, which was kind of a watered down version, and I think it only applied to people who had involuntary commitments. Can AOT be formulated for voluntary commitment, where a person says, look, I know that, I need some assistance. And the AOT is not an inpatient, you basically go home, but you just have certain commitments that you're to make. which could be counseling, it could be just, follow-ups. Can it be, formulated in a way that addresses those, issues that you and Ms. Billingmeyer had talked about, that, that it doesn't, force you per se to do things that you don't want to do, but it does at least require that you have some type of, let's say, outpatient, counseling.
I just think that needs to be really carefully looked at and studied. I'm not an expert, I'm a family member, but I have heard that in states where they did do a tremendous investment in community-based services, evidence-based, culturally competent, trauma-informed community-based services, that it has been more successful than in states where they just passed an AOT law without a corresponding investment in services.
And I just want to add that with AOT, so the whole point of AOT in general is you're talking about a person who traditionally does not want to agree to services. If someone is willing to agree to care, then there are already a whole host of different types of services that are available. And there's no programs that force people to do anything. You can't, force people to take medications or force people to come to appointments, but work with people where they are. That's what most behavioral health programs will do, but you still have to have someone who's willing to participate in care. So if someone's willing to participate in care, then they technically don't need assisted outpatient treatment, because you could just get them involved in an ACT team or get them case management services or outpatient mental health services. So.
Okay. All right. Yeah, Senator?
The other alternative I was thinking about was the Psychiatric Advance Directive. I had a client one time who had been long time hospitalized. He had struggled with schizophrenia. His dad had been in the legislature years ago. And one of the things he had requested was that if he outlined what he did when he was out of control, could he get one of his therapists that he named in that advance directive to work with him and get him back on?
You muted yourself.
Sorry. And that was, I think when we first started the community-based treatment, it was kind of an advanced directive. Once you left the state facility, you had to have that plan of care in place and all the therapists and other folks identified. So, and I think as Dr. Jones had talked about, that has morphed into type of advanced directive for psychiatric care.
Can that be folded into, and I don't know legally, as Ms. Harris was talking about, if it was just termed advanced directive for healthcare? Because, given, the potential stigma, given a person may have aversion to just essentially saying, I have psychiatric concerns. If it's termed, healthcare, and they identify a therapist or, a psychiatrist as well as a primary care doctor or a family member, does that address some of that issue?
So this is Carrie. Oh, go ahead.
Nope, please go ahead, Carrie.
Oh, okay. I just wanted to point out I'm actually working with a group right now who's trying to make advanced directives more accessible to people with mental illness and psychiatric issues. And right now, one of the frustrations is in Maryland, it's two forms. You fill one out for medical issues and one out for psychiatric issues. And so that obviously is a lot of extra work. And also, I think, the stigma, when really it's health.
Right.
It's health, whether it's, and it could just be one form, and you say, because I do think that's part of this issue with AOT, and is that for people to understand, everyone, not just patients, clients, and providers, but that it's about when you are so decompensated, schizophrenic, that you don't know what's going on. If you have that understanding, then you do have the control in an advance directive, a document like an advance directive, to say, when I do that, this is what should happen. And then that's where people have the power. And if we can figure out a way to make that easily accessible and understandable, because the forms can be confusing as well. So I think that is a way that what we've heard, a little bits and pieces from what people are saying, could, help this situation in some sense and give people some understanding that they have control over what could happen if it's in a document like this that could be then shared. And actually, there is a system right now where these documents can be completed and shared, uploaded to CRISP, which means all hospitals would have access to it in Maryland.
Right.
So, anyway, so I wanted to chime in on that because I think that is a good point.
Is the reason that it's separate forms due to how it's paid for? Medicaid or private insurance? Is that why we have separate forms for that?
I don't think so, but yeah, Dr. Jones might have a better understanding of that than myself.
Yeah, I don't think so. I think it might be about the licensure of the person who's completing the form. So you're generally talking about a medical, advanced directive by someone who has a somatic background to help someone make decisions about their medical care versus someone who has a behavioral health background. So you don't have to be a physician to work with someone on completing those forms. It can be a social worker or a licensed clinical professional counselor, doesn't have a medical background, so can't advise you or provide any support or answer any questions around general medical questions. So it might have something to do with that. I'm sure it might have something to do with from a legal perspective. We would have to get our AGs involved because it is a legal document.
Well, one of the things with lawyers and being a lawyer is sometimes you have to tell them what it is that you want, because lawyers are trained to tell you no, you can't do that, or no, you can't do this, you can't do that. But their job really is to tell you where the risks are. They're not to tell you no. And they should be, we should be able to talk to the lawyers in the department if it's, that how can we make this work? Is it just two signature lines? That you have the medical provider provides a signature and the social worker or the therapist provides a signature line. That you have, instead of two separate forms, I don't want the form to now be 25 pages, but it probably could, be something that is consolidated. So that, because I think it's difficult to get the person, it could be, maybe not, to sign two separate forms, and particularly if they don't think that there's anything, psychologically wrong with them. Why would I sign a mental health directive if, I don't think there's anything wrong with me and people are telling me something's wrong with me? I'm not signing that. I might sign it now because I think I'm okay, but someone else may have, a stigma associated with it. So, that's something we could probably take a closer look at and, talk to the legal counsel to find out why it is, actually why it's separate, and then see if there's a way to address this as an overall health issue, and that can be signed by, those under separate licenses. It doesn't have to be just what you want.
Just to chime in for a second, I would just note that the forms kind of come together and they're two different signature spaces because one element of it just deals with physical health and the other deals with mental health. And so you could have somebody who really only wants to articulate advanced directives with respect to, or appoint a healthcare agent for that reason alone and doesn't necessarily want to address the mental health component of it. So in just looking at the forms and having seen them in the past, that may be one of the reasons why, but that doesn't mean you couldn't have a consolidated form.
Okay. Yeah, just a thought. Okay. All right. I know we're getting past our time. And I know I put a couple of people, toward the end because they've testified previously, that Evelyn Burton as well as Dan Martin that testified previously. I noticed Ms. Ann Steinberg from PAMI, but I think there was also someone who testified earlier from PAMI. If I'm not mistaken, maybe I'm mistaken on that. But we're past our time at this point. And so I'd like to ask those who didn't get a chance to testify, if they have written testimony, to submit it on our website, on my website. And I do read those testimonies, and my staff also reads them. And they will be made available, of course, to the public as well. I want to thank everyone who was able to testify this afternoon. Thank Mr. Ornstein and Ms. Harris for their presentation, and thank all those who testified from the public for sharing their stories, as well as presenting their positions on some of the things that we're considering. Thanks again to the commission, and we'll be talking again. They probably told me the next time our meeting is going to be, and I don't know. Well, we haven't scheduled it yet. So, okay. We will be in touch with everyone and let them know when our next meeting will take place. Thank you again. Take care.
Thank you.